Dr. Myron later. But yes, I come all the way from South Africa, and we do have wild animals there, but it's the first time I've ever had a tornado warning on my phone. So it was very, very different. So I use PRF all day, every day in my practice. And this introductory course is one of my best courses to teach, because when I took it, it really changed my practice and my life. And it's also something that you can literally start back at your office on Monday. You'll have the basic skills to do this when you're back at the office. And what I found with any course I've done, whether it's fillers, Botox, the longer time I leave to implement it into the office, the less likely I am to do it. So with this course, I got back with my equipment, started, and I've never looked back. And then Dr. Myron contacted me one day and he said, hey, you're all the way there in South Africa, but you're using up all our tubes. What's going on? I just use it for everything. So what do I use it for? I use it as a potent skin regenerator. And you'll see some of my scar patients later, just for beautification. When I heat it up and make the biofiller, I use it as a filler-like substance, and I use it all day, every day for hair regeneration. So this is my job, hair transplants. So nothing really gets a result as surgery does, but I use PRF before the hair transplant, during the hair transplant, and also just to regenerate hair without a transplant. And most of you are dental, so it might sound like it's not exactly perioral, but actually the most queries I get after the course are on hair. And it usually starts with family and friends, and then people at the practice. So please visit my station tomorrow. It's one of the easiest injections you're going to do of the hair injections. And then South Africa is a very poor country, high unemployment rate, and we get a lot of cases where we're actually quite out of our depth. The cases of burns patients that are treated in government hospitals but then are just sent home to live their life scarred. So I have the privilege of treating a lot of these patients, and the power of PRF has become so much clearer to me. It keeps these patients' skin supple, especially the burns patients, skin that I think will never look normal again, and it never really does look completely normal again. But just treating these patients with PRF and microneedling alone, no lasers, no surgery, we get them to the stage where they don't have contractures, they're able to enter the public again. So I'll give you an example. This young lady had acid thrown on her, unfortunately by an ex-boyfriend, and stopped going to school, and it was all very sad, and I really thought, I don't know how I'm going to help her or how I'm going to respond. But what happens when you keep going with PRF, it's amazing how even burned and contracted and scar tissue actually heals and normalizes. So like I said, they never look normal again, but she's confident, she faces the world, and she went back to school. And unfortunately, she looked so good that she fell pregnant and now has a teen pregnancy. So, but the little baby's beautiful and is actually 1 year old now. But at the time, I was quite upset with her because she had to miss a whole lot more school. But she's really happy. So, if it can do this for burned and damaged skin, imagine what it can do just for anti-aging and normalizing fine lines and wrinkles. So it really is a potent procedure. It's all about self-esteem, so I do have the Instagram type of patients who want the perfect lip and jaws, so we also do a lot of facial aesthetics for the younger patients. So I love this saying by Isaac Newton, if I've seen further, it's by standing on the shoulder of giants, and that's where Dr. Myron comes in. So he has the giants, or the scientists in this case. So Dr. Myron has, how many degrees? 7 degrees. And he does all the research and the trials, and then I just take the bottom line and make my patients look great. So he does all the work, the clinical trials, and then he shows me with the last sentence. 700 RCF for 8 minutes to make them look great. And I'm great. And then so I'm a very practical person. So I'll be with you there tomorrow, that if you're standing in front of a patient, how do I inject this? How do I spin this? And that's the way my brain works. I also found out last time that he's like a champion musician and tennis player, and then last night found out was in the Canadian rowing team. So that's just crazy. But I'm the bottom line person. I like to know what I'm going to do and when. Okay. So Dr. Moran did introduce the other educators that will be here, but they've all really helped to improve my practice and just to improve the outcome of what my patients look like. Okay. So if you are dental, and this is a course and you're looking at adding facial aesthetics to your practice, it's a very joyful experience. And one of the ladies, the doctors from the advanced course, who did the beginner's course last year here in November, she came and said to me she loves her facial aesthetic days because it's not a grudge purchase. Patients are coming in giggling, happy with their friends, and it's a really nice thing to add. It's very profitable. You're using your existing skills. So I find with dentists, and I'm so intimidated with any working inside the mouth, but people are very, very adept at injecting, so it's a very easy group of people to teach, and you take to facial aesthetics very easily. And if you already have a PRF machine, then it's a no-brainer. Definitely to add this to your practice. Okay. So the two courses, in this basic course, we're actually doing very low-risk, high-reward procedures. Once you learn your techniques, not much can go wrong. And when I do my patients with PRF and microneedling, it's the one procedure where they phone me to book to come back because they're so excited. And why? Because, if one person comes up and says, oh, you're looking good, you're glowing, it's great. But if 2 people or 3 people come and ask you, what have you done to your skin? Then they really realize the value in it. And that's what the PRF and microneedling does. It rejuvenates, it gives you a glow, and they are phoning us. We don't even have to remind them when their year's up, phoning us to book their new one. So you're going to tomorrow be doing microneedling, injection of fine lines and wrinkles. So just those added little injections with papules, I'll show you in problem areas, add a bit more benefit. And adding volume to certain areas safely is what we'll learn tomorrow. The second course, the advanced course that's running with us, is more cannula work. So if you're already doing facial aesthetics and using cannulas, by all means you can. But if you're new to facial aesthetics and want to learn a cannula, that's for next time. But 90% of the results you're going to get and the improvements you can do from doing this course by doing your microneedles, your papules, and learning to add volume in certain safe areas. Okay. So I'm not sure if you saw these slides by Dermapen, but the power of microneedling is great. So not only in the scarred patients that I showed you, but by rectifying tissue back to normal. There are certain people and certain cases that only surgery is going to help them. I mean, if someone comes to you with the most hanging jowls or, really, really heavy eyes, they can be surgical candidates. But almost all patients benefit from the texture of their skin, improving under eye area, even if they've got bags, just to improve the skin quality and the color. So it's still worth doing. But there is a limit where something needs surgery. But there's a lot we can do with PRF. So this is an example of using PRF more as a filler. And I'll go into when you're going to heat it up and use it as a filler and when you're going to use it as a liquid. But you can get some very nice results. When using other fillers, like your commercial fillers, hyaluronic acid fillers, I find the under eye area can get quite a bluish tinge and it can get quite puffy. So it's one area I really like to use biofillers with. Okay. By the way, now that Dr. Moran's gone, he used a bit of my time. So if I'm going very quickly, tomorrow you can also ask me questions. Okay. So there are 2 talks in a row before lunch, which is quite a lot. The one is on facial anatomy, and the next one is on your basic injection techniques. And I'm obsessed with anatomy. I watch anatomy videos all all day, every day, and every time I watch someone's video, I learn something new. Or cadaver dissection, I learn something that we find about. So in this hour or so, it's really difficult to go through your anatomy, and you need to get onto facial anatomy. But there's certain things that I want to point out about the aging face. And when, in about, I'd say, 2005 to 2010, as aesthetic doctors, we started using a lot of filler. And what did we do? People came in complaining they had nasolabial folds. So we filled up everyone's nasolabial fold. And people didn't look better, and they didn't look younger. They just looked like they'd filled a nasolabial fold. And they said, okay, maybe if we fill in some volume and lift up cheeks, and people got this weird alien-like look. And what we didn't realize at the time, we weren't understanding the different layers of the face and what happens as you age. And that you can't just indiscriminately inject volume and expect them to look like they did before. So we started to understand that there are certain ligaments in the face that pull down and give us deep troughs, but there are also certain fat pads that descend, but some actually hypertrophy. So we started to understand far more of what happens when the face ages, and started to have a layer-by-layer approach, which is far more natural. A lot of people have mentioned Madonna from some recent appearance. I don't think we're all doing it very naturally, because that was a lot of volume, but I think things are a lot more natural, and we like to teach the layer-by-layer approach. Okay. So, as a general rule, a young, nice face is an upward V. And as we age, because of gravity and descent and deflation, the V turns upside down. So when you saw those microneedling directions that Dr. Myron showed you, and every procedure we're doing is to restore the natural V on the face and to get everything lifted up and out. So we don't want to volumize the jowls, and we'll learn how to do that with certain safe injection techniques. But we're basically aiming for that natural V up and out. Okay. Just a bit about the layers of the skin. So aging happens at every level, even the bone. The orbital sockets increase, and the fat pads descend. But what's very important about microneedling and about the little papule injections that we're doing is that if you've seen a papule or the depth that we're microneedling, we're not deep down where the blood vessels are. So that's why it's very safe to do what we're doing, because we're actually dealing with the dermis and the epidermis. So you don't have to worry when you're at those levels about obstructing a blood vessel, which is our biggest fear when we're using fillers. When we come to the deeper injections, when we heat up the filler and it's a little bit more of a sturdy substance, then we need to be very careful and inject into very specific zones. So we're going to learn about those points. Okay. So just a little bit more about what happens when we age. Basically, the difficult part about aging, and what you'll start to see from almost early 30s, are these facial ligaments that pull down. So basically, there's a ligament, and we always think of ligaments as in, orthopedic ligaments, but they're actual ligaments in your face that attach to the bone and join up to the skin to keep your face in place. And these are great when we're young, but as our fat descends and shrinks, what happens is they start to pull down. And when you look at an aging face, you need to see, you can actually see the ligaments so clearly. Some people start aging and the ligament pulls down here, some people down here. The ligament also, the xylomatocutaneous ligament will also pull here, giving you malar bags. And these ligaments are actually what are causing the problem, and they cause a valley. So when we fill things, we're wanting to fill the valley, but we're not wanting to fill the hill that's bulging above the valley, because then we're going to make that problem worse. So I'll show you what I mean from the side. So basically, in this lady, the orbital retaining, you can see the mouse, right? So this orbital retaining ligament is pulling tight where your tear trough is here and on the outside. But the fat above it, because of gravity, has dropped down. So you actually get a valley and you get a hill. So it's very important when you're assessing someone who's sitting in front of you, where are the ligaments, where are those valleys, and where are the hills? So we're not making any problem worse. Okay. So I'll go through an example of a lady and show you what's happening. So for example, this lady looks aged. She's probably going to come in and say, everybody's saying she looks tired. And a word of advice, don't ever tell a woman she looks tired. She doesn't like it. So she says she feels fine, but she wakes up and looks in the mirror and she looks tired, and people ask her if she's tired all day. So we can actually clearly see now that in this lady, her tear trough ligament is really pulling down here. She has some pull at the side, but I'd say that's mainly the main valley that's being created. But she's also getting this little puff here. And that's the zygomatic cutaneous ligament pulling there. So if we start to try add volume, that puff's just going to get worse. And the malar, the eye is fat that protrudes, but the malar area is usually fluid. So for a lady like this, we'd want to fill in the valley, which is her tear trough, and we'd want to teach her to get rid of her fluid and massage instead of adding volume and making the problem worse. And we definitely wouldn't want to put any filler on the hill that's above the valley, where her ligaments are. Okay. Similarly, if you look at the jowl, so the reverse camera on my iPad has shown us all jowls. So I don't know if you've ever been looking down and you turn your reverse camera on, and the first thing you notice is the jowl. And what happens, and I'll show you a diagram of the ligaments now, but there are two ligaments that are like a hammock, the poles of a hammock, that are pulling tight here. But gravity and the rest of our face is descending, so it's descending into the jowl. So once again, if you're doing any injections in the lower part of the face, we're wanting to get back to that V. I actually take my pencil and I cross out. Do not put any volume here, because once they lie back on the bed, it sort of disappears and you might start injecting, and then you're actually worsening the jowl. So what you do is you can inject behind the jowl, but you don't want to add any volume there. So when you're assessing the aging patient, look where all the ligaments are, ask what are people saying. Are they saying they're feeling tired, angry? So angry can be downturned mouth, like we call it resting bitch face in our family. But it's often they'll come to you and they'll say, they say more of an emotion. So first ask them that, then see where you think all the ligaments are, then mark out the no-go zones where you do not want, you can't take away volume unless we send them for surgery, but mark out all the no-go zones where you don't want to add any volume, and then start from there. So this is just a picture of all the ligaments on the face, but the ones that really cause problems are the ones that hold up the nasolabial fold, the tear trough ligaments, the orbital retaining ligaments, and those two, the 10 poles of the hammock, which is the masseteric and the mandibular cutaneous ligaments. And everything else falls down from here. Here's a picture of the ligaments without the fat pads. I don't know if you guys all got the Dropbox presentation, but it will also all be on there. Okay. But basically, you don't even have to know the name of the ligaments. You can see so clearly in somebody's face where they are. Okay. And that's causing all the effects of aging. Apart from the ligaments, other things that happen with age, and you'll learn a lot more about the muscles when you're doing the Botox course, but the orbicularis oris starts to pull in and down. So what happens, and especially in females, as we age, the length of the fulcrum gets longer. So when you're doing a lip, the last thing you want to do is make it heavy and pull even lower. So all our lip treatments for aging, did this go off, are about everting the lip and getting it slightly up to try and reduce that length. Another thing that happens is a hollowing of the temples. So when you're looking at no patient really comes in and says, doctor, my temples are hollow, please inject them. They'll come in and they'll say, my eyelids are feeling heavier. And yes, the skin of the eyes get droopy, but it's also about they've lost support in the temple area. So that's another area that we can inject. And it's also a sign, in my country we have unfortunately a higher rate of HIV positivity, and it's a big stigma. And that's really where I learned to inject a lot of temples, is that malnutrition, temple hollowing, aging is the hollowing of the temples. So although it's not you might have to actually convince your patient they need an injection in the temple. It actually can lift the eye up and out, give the almond shape of the eye again. And especially in someone who has a very hollow temple, it's a very rewarding area to inject. Okay. So that's just a glance at the aging face. Like I said, I spend hours and hours studying anatomy videos. But what we go over every single time are the facial danger zones. So any filler conference, and what I mean by filler is not our biofiller, your hyaluronic acid fillers like your Juvederm, Restylane. Any conference you go to on filler, 50% of the talks are on safety. Our biggest fear of injecting filler is causing blindness. When you inject into a vessel and it goes retrograde flow into the retinal artery, very rare, but there are cases reported around the world. Second biggest fear is blocking an artery and causing necrosis of the skin. Luckily, when you look at PRP and PRF and the regenerative protocols, if you do an entire literature search, I found 3 cases in the world of vessel obstruction. They were all with PRP. So there are no real cases with PRF yet, but we don't want to be the first ones. So we take all precautions as if we're injecting filler. Also, it might be a natural progression that after you start with PRF, you might progress onto fillers and Botox. So get into the habit from the beginning of knowing where the danger zones are and really just understanding your anatomy and where not to inject. There's certain areas, even as the most experienced injectors, that I just refuse to inject because it's too risky, whether it's biofiller or filler. Now the difference is, with a hyaluronic acid filler, there is a substance called hyaluronidase that can dissolve it. When we're working with PRF or biofiller, there isn't a substance. So I always get this question, what would you do? So, like most, the first choice, I'd say, is to just please never ever get an injection. And we think that if you inject the biofiller into a vessel, it seems to be fine. Whereas if you inject hyaluronic acid into a vessel, it's very thrombogenic. And that's why they get these blockages. But I'm still extra cautious, and I still follow the same protocol if it ever happened. And like I said, we don't want to be the first people to happen. So there are, I don't know if you've ever seen that meme where you just see all the skeleton with all these blood vessels, and then the patient gets upset because you bruise them. Obviously you can bruise a patient, the blood vessels are everywhere. But there's certain major vessels that we need to avoid and need to know. So I'm going to go back one slide. So these are the areas we worry about. Glabella, this is the common area that caused blindness, is injecting in this glabella area. Okay. So I never ever inject deep into the glabella area. Now remember, as Dr. Myron said earlier, microneedling in your papules you can do anywhere because they're superficial enough not to get these vessels. So we're avoiding these with the deeper injections. So you can tap your here, you can microneedle here, no problem. The minute that needle's going deeper, you need to avoid the glabella. And I'll show you now when we're going over the arteries. Temple, there's a very specific injection point we use that's safe, that you're going to learn to inject the temple. We don't do a lot of biofiller in the nose, but if you go onto fillers, it's a very tricky area to inject. There's a lot of vessels at the side of the node that can be dangerous. The lip area is it's a common area for complications because it's injected all day, every day. And the most common injections around the world that are done are lips. So just because of the huge number of lips that are being done, there are complications. So it's very important to know where those vessels are, which we'll go over. in the infraorbital area, there's a little notch where the vessels and nerves come out, but we avoid that with all our injection techniques. And then the nasolabial folds. The vessel, it's a tricky area because the vessel becomes very superficial. But let's go over what we do know. Okay, so looking at the skin, it's very tricky unless you have an ultrasound to see where the arteries are. But there's certain things that we can be pretty sure of that we do know. So let's divide the face into thirds, taking the upper third of the face. If you take the medial part of the iris, so not the pupil, the medial iris, and you go straight up, in almost 100% of the people, that's where you'll find the supraorbital artery coming out, either through a little hole or a notch. This was a cadaver study done by a group of Chinese doctors where they studied 2,000 cadavers, which is a huge amount when it comes to aesthetic medicine. And almost 100% of the time, it came out directly in line with the medial iris. And the 0.02% that didn't, it was within a millimeter. So we're pretty much sure that the supraorbital artery comes out here. It comes from deep to superficial. The reason we really want to avoid injecting into that artery is it has a direct channel to the retinal artery. Okay. Then, if you ask your patient to frown, and if they've had toxin, you might have to help them frown. If you take the medial frown line, almost all the time, the supratrochlear artery is running in that frown line. So there's nothing more tempting. We've got this filler. We can see these number 11s that people get when they're angry and we want to fill them up. That's exactly where the artery is. You do not want to inject those areas with any sort of filler. So it's a pretty good guess that we know that it's in the most medial frown line, and we know where the supraorbital artery are. So they're coming from deep and they're going superficial because they want to feed the frontalis muscle. What we don't know is where that it's coming from deep to superficial, where it's going to end up superficial. So we avoid an absolute no-go zone of any deep injection is this 1.5 centimeters. So the glabella area and 1.5 centimeters. So all I do in that area is I microneedle and I do papules and Botox. It's a very responsive area to Botox if you do Botox. So avoid any deep injections here. Even the most experienced injectors have run into problems there. What else are we sure of as far as the blood vessels go? If we take the lower part of the face and we track the facial artery, about in line with the lateral canthus is your common carotid, and then it branches off, and the facial artery, if you tense your masseter, just in front of the masseter muscle, you'll feel a notch. And that's where the facial artery crosses over onto the face quite deeply. Okay. So that's another area where we're going to be very cautious and maybe use a cannula, which is a more advanced injection, is along the jawline. Sometimes you can even feel it pulsate, but it's always there. Then the facial artery is very tortuous because it's not that stretchy and the face needs to be able to express. So it's very twisty, turny, very difficult to feel. But we know that if you take a little box of 1.5 centimeters from the modiolus, that's where it's going to branch into the superior and inferior labial arteries. So that's pretty consistent there. And then it takes another tortuous path to the angle of the nose, and that's where it becomes very superficial. So if you're doing nasolabial folds, you either need to be right down on the bone, there at the angle of the nose, or you need to use a cannula. So it's not one of our safe injections. Okay. So I really advise you just to get family or someone from your office sitting in front of you, get a red pen and just map out all the injections that you know, just until you get used to it, and just to be very, very aware of where those injections are, and not only in a two-dimensional plane, also about the depth of how deep and how superficial they are. And we'll go over some of those when we're actually going into injection technique. So this is what we're trying to avoid, where a vessel is blocked and the skin is actually starting to necrose. Okay, that's not with biofiller, it's with actual hyaluronic acid filler, but that's what we all are scared of. I don't want to scare you before you even start, I just want to get you into really good habits. There's some really nice apps, and I've forgotten which app this is, but you play around with your own face and play around with your patient's face just to get you used to where those are. Okay. But don't worry, we're going to teach you all the tips to actually keep you safe. And this is that, oh, look, it even moves. Okay. And this is that meme they always have is like, doctor, might I bruise? Yes, you might bruise. But we're aiming to avoid the main ones. Now, if someone's had any form of facial surgery, nose job, facelift, yeah. I'm going to find it for you because I can't remember the name of it. Yeah, I'll find it for you. So if someone's had any form of plastic surgery, which people don't always admit, the vessels are usually very distorted. So then you can't take these knowing for sure where they are. So just ask that as a question. So how do we stay safe from all of this? The one thing is injecting small amounts and injecting retrograde. So you'll see, apart from the papules and the microneedling, which are very safe, any longer or deeper injection we inject as we're coming out. So we're less likely to be forcing this substance into a vessel. We use tiny syringes and needles. And when I first came to the US 5 years ago, we really struggled to find the tiny 30-gauge needles. They weren't commonly used here, and now we've got beautiful quality 30-gauge needles. So they're really tiny, which helps a lot with safety. Knowing your facial danger zones, so definitely not here. I don't do any nose injections or glabella injections. And when we go over the injection techniques, we'll learn certain entry points that are definitely safe. Use the smallest gauge needle as possible. It does test your eyesight because you have to be able to see where the bevel is. So if you can't see the bevel on that 30-gauge needle, you need glasses. When I started doing the course, I could so easily, proudly see it, and now maybe next time you see me, I'll be wearing glasses because it's, especially in the lighting in these rooms, it's tiny. Pinch or tent the skin if you're doing a deep injection onto bone. You can pinch it, actually lifting all the vessels up. So in the cheeks, we actually do go right down to bone. So that's a nice area to pinch or tent. Assess the level of pain. Now this is very hard in men because men find a lot of things very painful. So assess first of all how they are, but it shouldn't be a screamingly painful injection. So yes, it's a bit of a prick when you go through the skin and put the needle down to the bone. It's a bit of a weird feeling, but it shouldn't be excruciatingly painful. So go slowly, assess, and if it suddenly becomes excruciating, rather stop, find your place again, and go somewhere it's not. Because you might be hitting a little nerve or near a vessel. Okay. There are vein lights, but vein lights are great, but they only identify the veins, so it helps with bruising, not really with the arteries. And in the face, the veins are usually far more lateral to the arteries. So I love vein lights, and you'll use them for phlebotomy, and you can map out the veins on the face, you create far less bruising, but it doesn't necessarily keep you safe from the arteries. And then, like I mentioned before, use extreme caution if there's been previous trauma or scarring. Okay. What are the contraindications to PRF? There are not many. So officially it's platelet dysfunction syndrome, thrombocytopenia, any hemodynamic instabilities, and septicemia, and patients with unrealistic expectations. That's a big one. But for me, it's more, if I find, and it hasn't happened very often, but to me, if the blood just doesn't look right, like I've had 1 or 2 times where somebody's coming slightly ill, the blood is thick and sludgy and oily, and I'd rather just get them to hydrate, come back on a different day. So I don't necessarily do baseline blood tests on all patients unless they've been ill, but I have had times where I preferred not to use the blood. Relative contraindications of heavy smokers, liver pathology, metabolic disorders, all your cancers of hemopoietic origin. So I've had questions, can they have it during breast cancer and things like that? They usually can, but I like to wait 2 months after any form of radiotherapy or chemotherapy or any cancer, just because the results will be more optimized. Low platelet counts, recent fevers, non-steroidals. This must be when they phone in to book an appointment, at least 5 days prior of any form of non-steroidal anti-inflammatory drugs. Prednisone, so we actually relying on an inflammatory reaction. So anything that's going to suppress that in the next few days, even high doses of turmeric, rather just that we want that inflammation to occur. So especially your prednisone, and then anticoagulant therapy. So I don't take it, so for example, an old patient with a hip replacement, I don't take them off their anticoagulant therapy to do the facial treatments. I don't think it's ethical, but they might have a slightly dampened down result to most people, but I still do it. But if it's someone who can easily just come off for 3 days, then I'd take them off. But Dispirin or aspirin really affects platelet function, so that you must be really strict about. Okay. And also viruses, but like I said, I actually don't do baseline blood tests. I'm working with a blood product. I just assume I take all precautions in every single patient. And when the vampire facial became popular, because Kim Kardashian did it, so we were doing all this amazing work with PRP back in the early 2000s, and nobody knew what it was. They didn't want to pay for it, pay the extra money for the healing, yada yada, until Kim Kardashian had a vampire facelift. Then all of a sudden everyone was phoning in and saying we want a vampire facelift, and it sort of put it on the map. And then a few clinics got a very bad rap, and that was because they reused needle tops. And two patients got, there were 2 cases of patients who became HIV positive with a vampire facial. So it's got a very, very bad reputation. So obviously we're dealing with blood and blood product. It's 1 needle per microneedle, all the usual precautions that you'd use with blood and blood product. And in fact, you actually can't use those needles twice. Once they're in and collect the dermapen, you can't reuse them. Then I think this is the last of this presentation. So this is my Instagram. I'll also put my email on the Dropbox. Most people actually message me to Instagram if you have any queries, and you're most welcome to.
Quick question of herpes. Like, you with every patient who will tell you that they get the herpes like once in a while, you're going to go with the prophylaxis with every single one?
Yeah. Especially if I'm microneedling, or if say example, I was just doing the eye area or something, maybe not. But if any microneedling can definitely activate it. Yeah.
Question. To prevent injecting into the artery, would it be helpful to aspirate the needle, or is that?
So yes. So with the liquid, you don't have to, and you really can't. And the liquid's really not going to obstruct an artery. So any PRF liquid we're doing is fine. Once we're making that filler, it's definitely useful to aspirate, and you've got to get into the habit of every single injection you're doing aspirating. However, it's much more difficult to aspirate with PRF than it is with your normal fillers. So with the normal filler, you go in, you aspirate, you wait a little bit, there's a nice clear bubble that comes up. It's not like that with PRF. But nevertheless, get into the habit of still aspirating. And that's when you're using a needle. I know it's a lot of slides for you, but we're going straight into the presentation before lunch. Presentation number 2. Let's see. Okay, great. So a bit of a paradigm shift. What I want you to think of is these slides as questions that you're going to ask yourself tomorrow when the patient's in front of you. So I've never seen a more hands-on course than this. I mean, tomorrow is chaos. It's such a fun day, but you're literally learning all your skills running around. So that's why I really oversimplify things, because that's how my mind works. When I've got a patient in this room in my practice, I just want to remember this protocol, these injections. It needs to be really simple for me. So I just want to simplify everything. So first of all, just so that everybody's on the same page with the languages, because some of you are used to working with IPRF and APRF, but the new terminology, so basically we microneedle with the BioPRF liquid. You're going to inject fine lines and wrinkles with the BioPRF liquid, but anywhere where you want the volume to stay a bit, and where you want to create a bit of a plumping, that's when we heat it up. And we're going to use biofiller, and that's where we need to start being careful about vessel obstruction. So what I find is most of what you're going to be doing, and the benefit is from the liquid. So the liquid is like a secret sauce. It's got these rejuvenating, regenerating properties. So anywhere where you want to get fine lines and wrinkles, hair growth, anywhere where I'm not wanting to leave volume, I'm going to use the liquid. So crow's feet, the places I would want volume is a bit of a cheek and a bit of a lip. So that's really where I'm going to be using the biofiller. Okay. Now in dentistry, you use red tubes, you create solids, which I've got no idea what they are. So yes.
We can't see any slides right now.
Oh, sorry. Okay, let me go right back to this. I didn't listen, I didn't mirror it. Okay. Perfect. Thank you for letting me know. Okay. So basically, in facial aesthetics, you're going to see no red tubes. You're going to be making no solids. Solids is a different thing to the biofiller. So all you're going to see tomorrow are blue tubes, and none of those solid trays. And there are two different settings you can do for PRF. This is where it gets a bit confusing tomorrow. So if I'm wanting to make the richest liquid have the highest concentration of growth factors and just stimulate every cell in the body, I'm going to do my very low, so my 300 RCF for 5 minutes. That gives me the richest, most beautiful PRF liquid, small amounts, but that is what I'm using usually when I'm doing hair or my little tackle injections, and it's wonderful. If I'm wanting to make the biofiller where I want that larger amount to boil it like the albumin, like egg white, then I do my 2000 for 8 minutes. If I'm wanting to do both of those, I need 2 machines. Okay, so to confuse it even more, tomorrow, and you can do this in your practice as well, all the machines are going to be set for 700 for 8 minutes. And that's the happy medium between the two. So you don't need to change anything, so you'll get rich enough liquid, but enough product to do your biofiller. So you can set your machine on this when you get back. It's a lot simpler. You can use it for everything. And everything tomorrow will be, and check that your machine is set at this, it'll be 700 for 8 minutes. But if it's a clinical trial or a patient who really wants that richer PRF, then you can change the setting to 300 for 5 minutes. But tomorrow we'll be doing all of this. Okay. And I made a lot of mistakes so that you don't have to. So one of those mistakes I made is not plugging in my machine and setting it, and then forgetting I've only got 90 seconds to get the blood tube into the machine. So even though they've been set up for you tomorrow, make sure it's working on the right setting. Another mistake I made so that you don't have to is I put my bioheater on, but I didn't push start. So I was all ready to make the biofiller, and now I have to wait for it to heat up. Okay. So another thing when you're at the station, check that your biopool is cold tomorrow. If you're making the filler, check that you've pressed start. Once it's started, it can run the whole day. But if you just turn it on and don't start it, it doesn't start heating up. And then the oven, check that your centrifuge is set and that you've fought whoever's working next to you, that you've got your centrifuge for your blood. And then, because we're not in a hospital setting, we're very, very busy tomorrow, please mark your tubes. So once you've drawn the blood, and we are sharing centrifuge, we usually have our own, but we put them in the stands, just mark them. And if you at any time not sure if it's your tube or not, throw it away. Just be extra, extra cautious with that. So as you draw blood, just identify your tubes in some way. Great. So as Dr. Myron mentioned, you can microneedle round and round in circles and you're still going to get a result. You can buy a microneedling machine off Amazon and you're still going to get a result. But this environment is so competitive. We want to optimize every step of our protocol, and we have optimized it. First of all, so that we're consistent, so that if we're doing any trials or comparing, we've optimized everything, but also just because it's a very competitive environment and our patients want to look the best that they possibly can. And these are word-of-mouth procedures. So how have we optimized them? First of all, we use the richest PRF in growth factors, so we use those beautiful blue tubes which don't have any silicone in, which I'm sure you learned all about yesterday. Optimal phlebotomy, which Marvin taught you, and you'll practice again tomorrow. And with that means getting them into the machine in 90 seconds, so you don't have time to chat. The patient always starts a conversation as you need to get them into the thing, like, oh, they're giraffes in South Africa, yada yada. Sorry, I'll tell you about the giraffes now. Get the tubes in, push start, and then I'll talk about giraffes in South Africa. So that's optimizing it. The horizontal centrifuge has been an amazing change as well, that the buckets swing fully out and pressing your syringe. Optimizing microneedling, and I think you have a demo today on microneedling. You'll see how Lauren has optimized every step. So we use the best device. That orange needle that Dr. Myron showed you is the microneedling needle that you only use once, and mistakes I've made so that you don't have to. It's very important how you put them on and take them off. So please take note of what Lauren does today. Once you're paying for them yourself, you'll realize you do not want to waste those needles. And you can actually break plastic in the machine. So she'll show you how to line it up, click it on, click it off. If you're not sure tomorrow, there are loads of people helping with microneedling. Then we've optimized of that thing that you took a photograph, that lady's face, the depth and direction, and also just our injection tools and techniques. So patients will ask you when you start doing this, and the best patients to start on are your staff or family, and from the get-go, take before and afters. Because those original people, your results, you can't really mess it up. You can just it's really amazing or slightly amazing. So take it before and afters, and people say, what is this PRF and microneedling going to help me with? Why was everybody going mad about that vampire facial? And by the way, that's a patented term. So that's a PRP is patented by someone. You pay him every month to use that. So we can't use vampire facial, but we do something better anyway. But just so that you know, so that you don't start advertising under that. But what is it actually great for? It's great for pore size. So anybody that struggles with pores knows that no product, cream, gets rid of pores. The only thing that really works for pores and pore size are microneedling with PRF and lasers. It's great for pigmentation, amazing for fine lines, fantastic for acne and acne scarring, which is a very, very common condition in my practice, for blemishes and just for improving cell turnover. And what does improving cell turnover do? It gives you that glow. And it makes a base for everything else. So a newborn baby and young children have a 28-day cell turnover. The minute that gets sluggish, problems start to happen, skin builds up, products don't penetrate, you can get things like psoriasis, eczema. It's all about the skin barrier and that product turnover. So apart from getting that beautiful glow that everybody comments on, it really helps with things like rosacea. It helps with penetration of your normal products, they start to work better. If you're having other treatments like lasers, like Botox, if you've improved the skin as a canvas, they start to work better. So if I had my way, and unfortunately patients are quite impatient, I would do my 3 microneedling with PRF before I started any other treatment. And get the skin as healthy as possible as a canvas if I made their master plan. But it's often not like that. They come in and say, in 4 months' time, I have a wedding. Yes, so I don't have a laser, but you can do it on the same day, same session, definitely. Laser and microneedling, so improve the skin as best as possible. Always the laser first.
So with skin conditions like rosacea or eczema or anything, there's no contraindications for microneedling. It will help.
It really helps. And in fact, there's one lady next to I'll try to show you that when she did her first course, had quite severe rosacea. That's completely cleared up.
A lot of my patients are strictly aesthetic
Yeah.
practice. A lot of my patients are on a very aggressive skincare regimen, retinol, Tret, HQ.
Yes. So
Can I microneedle while they're on? Do I hold it for days?
3 days before with the
Okay.
retinols, and then 3 days afterwards. And if you've done laser as well, then I wait 5 days afterwards. But
Do
they
I
must.
have to hold hydroquinone or tretinoin?
No, the tretinoin, yes. So retinols and tretinoin 3 days before. Yeah. Perfect. Okay. Great. Okay, so Dr. Myron did show you this, but if you don't have this in front of you, they are all over tomorrow. I just want to quickly go, and it sounds so basic when we do it today, and then tomorrow I go, and then everyone's doing microneedling like this. But don't worry, that's what we're there for. But remember I was talking about the V. I do believe that the direction of microneedling does help because you're building your layers of collagen in that direction. So the easiest way to look at this chart and to start off is, like Dr. Myron said, everything's up, sideways and out, except the nose, which is down, and the upper lip, which is down and out. So those are your directions, and then everybody just correct everybody, because it's so easy when you're watching and not as easy when you're doing it. So if patients start doing it down, it's just up, sideways and out, and those are your passes, and go right up to the ear. And then down on the nose, down and out on the upper lip. Then when it comes to depths, this is a mistake I made, so you don't have to. On the microneedling pen, it goes up to 2.5. Don't mistake 0.25 for 2.5. So usually around the eyes we do 0.25, and if you're going to do 2.5, it's very deep. So just play around, you'll see in the demo today of which is 0.25 and which is 2.5. But the easiest, if you don't have any clue, and if you're starting on a new patient and you're new, I find the easiest way to do it is everything is 0.5 except the cheeks you'll find are not painful. So I go up to a 1 on the cheeks, they're very fleshy, and under the eyes I go down to a 0.25. So that's a basic, but tomorrow they'll push you and you can go deeper, and if it's a new patient, definitely. Neck, décolleté, we'll show you a bit of that tomorrow. Definitely, so we actually treat the face as this area, yeah. Oh, so they're the across. So you're going to go with your microneedle, you're going to go up, out, and up and across. Is there an extra line there? Yeah, so it's just 3 directions. And I think of it all as making that V. Okay. And then don't be scared to get, there's a lot of gunk around people's nose. You can go right to the nose. The nose is quite sore actually, but you go down the nose. So the way it works tomorrow, if you, some people are lucky enough to bring models, but we usually work on each other. So my best advice is the local anesthetic cream. It helps a lot, but it needs to be on for some time. So if you're about to do your procedure, get in there early and put your numbing on so that you're all ready. Because most of the time we're like, oh, there's not enough time left, let's just microneedle. Which is fine without the cream, but it definitely helps So there are tubs of local.
What's the optimal amount of time to work?
30 minutes. 30 minutes. Yeah. So you'll see with Lauren, who's very proficient, she probably does it in about 20 minutes. But what I do is I book an hour, the patient for an hour. So somebody in my practice will help them to clean their face, because you don't want to be microneedling in any makeup or any dirt. Then they'll sit in a nice relaxing room with if they're doing the local anesthetic. And then with me, it's usually about 20 minutes. In the beginning, it took me maybe 30 to 40 minutes. Okay. The only thing I don't know about is prices, because in South Africa, everything is 10 times cheaper. So, yeah. So, not to get into too much detail, but I've seen PRF and PRP advertised as stem cell treatments. There are 1 or 2 stem cells in there, but what it actually is, it's a growth factor treatment. And the growth, there are 64 growth factors, because often, you come with this beautiful yellow stuff and your patients say, oh, what's actually in there? I tell them it's full of all these growth factors, but the ones I love for hair and for skin are these. So VEGF, your vascular endothelial growth factor, and what you'll see is this beautiful pink look. So when we've injected the scalp or microneedle, you get this, apart from a little bit of blood that's spread around, you actually get a pinkness. And that's already your VEGF creating new blood supplies. In the long run, it causes angiogenesis, but it just improves blood supply. Fibroblast growth factor, they're quite a mouthful, these growth factors, but of course we want our fibroblasts stimulated, creating new skin. Endothelial growth factor, COL1 and COL3, which go very nicely for skin and hair, and transforming growth factor beta. Those are my favorite, but there are a whole lot of other ones, and probably ones we don't even know about. And there are the odd stem cell in there. And then, it's not on my slides, but like I said, I really like to oversimplify things. So, when you're looking at all this new exosome technology, all an exosome is when there's a stem cell, which is cellular, and it needs to give a message to a cell anywhere else in the body. So I always look at the stem cells like the CEO of the company or the Army General, and the exosome is the email he sends out to everybody. And it's just this little vesicle, it's got a bit of RNA in it, and other stuff that travels to give the message. So the difference between PRF and exosomes, and you can definitely marry the two, is that exosomes is cell-free. So it's usually not autologous. It's off a shelf. It's cell-free. Sometimes it needs to be cold chain, but it's not the patient's own. It's off a shelf, and it's those little vesicles of messages. So they've taken the email that tells the body how to regrow hair and made an exosome solution for hair, and for the immunosomes and all of that. So those are your exosomes. They're pricey, they're very new, and they're an amazing add-on. But what's amazing, what I find, is that we're using our own patients to get their own growth factors and stimulate with PRF. But you can definitely use the two together. Okay. We've seen these amazing results. Okay. So then, sorry, does anyone have the time? I just want to see how much time I've got. Oh, good, okay, so I've got a little bit of time for lunch. Okay, so 90% of your happiness from your patients is going to come from PRF and microneedling. Like, just don't underestimate how amazing those results are. But there's certain areas where we need a bit more. So I always assess the patient for problem areas, and the two problem areas are usually crow's feet and lip lines that need a little bit more. So I microneedle everyone, everywhere, but I do small papule injections into problem areas. Okay, and the reason is I'm not trying to fill up the line because the fluid's going to go. I'm trying to build a papule. So if you expand skin in a 3D dimension, whether it's with a suction cup or with an injection, it stimulates the fibroblast even more. So in the problem areas, we're going to do these little papule injections, and you're all going to practice those tomorrow. And those papules just help that extra oomph. So this technique of papule injections is actually called mesotherapy. It's done a lot in France, it was developed in France. But we've added it in with the PRF just to provide a little bit of extra help in those areas. I usually do the papules before microneedling because we use such tiny needles that we don't want the liquid to clot. So the order of things would be first identify your problem areas, maybe your crow's feet or some lip lines. Do your papules. I mean, you can do papules anywhere, but do your papules in problem areas, and then you do your microneedling, because you don't have to fit with the microneedling, you just drip the liquid on the face. You don't have to fit it through a small needle. So how do we do the papule? And now remember, with the papules, you don't have to be worried at all about your vasculature, because the minute you're making a papule or a mosquito bite, you're safe, you're in the dermis. I'm above all the vessels, and it's a liquid, so I'm not really too worried that it's going to block. So what I do is I get my tiny needle, and you'll see, this one's blue, but you'll see tomorrow they're yellow, they're 4 millimeters long, they're really tiny, and you're going to turn the bevel up, so you need to be able to see the bevel, and you just put about half the length of the needle in, and then I inject a tiny drop, and I want to see a little bump. I want to see that papule. In the scalp, you don't get papules, but anywhere on the face. It's very nice as well for necklines. For ladies who sleep on the side, they sometimes get lines down here. Men who sleep on their face often get a line running up there. Just the problem areas are very nice to do papules. And it really just gives that extra little bit over the microneedling. So this is someone who's, like I said, in France they do microneedling all over, papules all over, and don't do much microneedling, but we combine the two. So these are what the little papules look like, and the patient sits up and it looks quite dramatic, but it really goes down after about half an hour, and we put these nice marks on after everything, and then by the time they're driving home, it's really, really settled. But it can be a little bit jarring when they sit up. Okay. So just to remember, the papules are for these fine wrinkles and to try lift them up. It's not, for example, for a deep groove, like a nasolabial fold, or to volumize the cheek. This is more thickening collagen and thickening skin on that level, whereas the biofiller is adding more of a volume or heel. Because I have sometimes seen people try to do papules with a biofiller, so you don't want those permanent dumps. Okay. So tomorrow you'll have all these needles. We won't be doing cannulas in the first course, but if you're used to using cannulas, by all means, if they'll be there and you can use them. But what we're going to be using most is the tiny yellow 4 millimeter needle. So it's yellow, it's 4 millimeters, but because it's so tiny, it's very comfortable for the patient, but you don't want to wait too long and let the PRF thicken or clot, because it's going to start blocking in the needle. So we do have coolers there, which keep it liquid for a lot longer, but you do have to be quite organized in your practice with PRF. In that they can't go out for a smoke break, they shouldn't be smoking anyway, or do another patient while it's sitting there. You want everything set up, marked out the areas that you want to inject, and be ready to go.
Previously you said something about needles for the papules.
Oh, sorry, the picture was blue, but so that blue that I had is a 34 gauge, it's even tinier, but we're going to be using 30, which is perfect. Yes, but ignore the blue because I couldn't, you don't really find them much here. But the 30 gauge is perfect, so use the yellow. I just didn't have a picture there of the yellow. Okay.
Optics. Do you stay away from
It's after the microneedling, yes. Yeah. For that day, definitely. But just in general, you have like a bit of a red sunburned feel for about 3 days. But I always like to get them into a good sunblock routine. Okay. So the 2 needles you're going to see tomorrow are those tiny yellow 30 gauge that are 4 millimeters and the big orange 25 gauge. So it's quite a big needle, but it's the only needle that thicker biofiller fits through. So don't try and inject the biofiller through the yellow. So whenever you're heating it up and making filler, you're going to need that thick orange needle. So those will be the 2 that are there tomorrow. Okay. So if you're ever intimidated to inject anything, inject my hands. I always love having my hands injected, but I just wanted to show you a papule. So it's very simple. Bevels in, do a tiny injection, and it's done. If you're working around the crow's feet, start from the outside going in, because it's just quite intimidating if you just start close to the eye. So you track the lines, and you're actually injecting your papules into the lines. You're following the lines. So please all do those tomorrow. Okay. If the patient does Botox and fillers, they need to be it needs to be a week apart from the microneedling pure. If you don't want to be pushing that Botox in. I like to do the Botox after, not before, and the reason is I like to see the lines. So sometimes if you Botox the crow's feet, the lines aren't clearly there anymore. And I like to very accurately inject into the lines. So if there are Botox patients, you do the PRF and then a week later does the Botox. And then they definitely love it. Okay. So I was saying before that some patients are surgical candidates. But even so, in your older ladies, just by improving skin tone and quality, with time you get a lot of improvement in their skin. The lighting's not so good on these pictures, but even with crow's feet, without Botox, you get improvements. And this lady, I mean, I'd never think anything would improve her jowl, but just by continually improving her skin, her jowl has improved. So, tomorrow in the chaos, luckily now you've got stations that you have to visit, but by Monday you should all be able to microneedle with PRF. You're going to be doing a lot of that tomorrow. It's super simple, but just get into those good habits from the beginning and learn how to basically work your device. Please all do those little papule injections. They're so easy, but they add so much benefit. And then I'm just going to, the 2 safe areas that we can inject with biofiller are lips and cheeks. If you're starting off doing lips, start with the liquid until you're very, very comfortable at doing lips. Even though the volume will go, it still rejuvenates the lip, and it's a nice way to learn on the lip before using biofiller. But I wanted to talk, okay, I'm not going to go into the danger zones again. I just wanted to show you, so before I talk about the cheeks, this is just what a papule, sorry, it's the blue again, but it should actually be a yellow needle. So that's just what a papule looks like next to the eye. Okay. Then I wanted to talk to you a little bit about the cheeks, because this is really an area that benefits from a bit of volume. So if you're planning to do biofiller in your practice, that's one area I'd really like you to inject tomorrow. So a lot of the problems of the lower face actually come from the cheeks. So people used to, like I said, we used to fill up nasolabial folds and wonder why they didn't look better. But if you address the mid-face first, when that V collapses, the cheeks fall in and down, and you get jowls, you get nasolabial folds. So a very good place to start is to rebuild the cheek. So we're not trying to build a model cheekbone. We're just trying to support the lower and the mid-face with the cheek. But when we started doing cheeks, we got some very funny looks and just overfull people. So a very clever guy called Hinderer developed these lines that we draw on our patients that guide us to a specific place that's safe to inject, but it's also called the point of beautification. And the reason it's called that is because that's where when you volumize that area, the light shines optimally, but it also pulls everything up and out instead of just giving you a big apple of the cheek. So we're actually going to learn to draw those lines tomorrow, and there are white pencils around. But basically the lines, if you take the lateral canthus of the eye to the angle of the mouth, so that's your first line, and your second line is from the corner of the nose to the tragus of the ear. It makes a grid. And in the upper outer quadrant is where the beautification point is. So in that upper outer quadrant, you're wanting to inject onto the bone. If you put your needle in and it's soft and there's no bone, you're either too high or too low. So you draw those quadrants, and then remember when the patient lies down, everything changes. So you draw them sitting up, and then with them sitting up, you can play around with that area and see what's going to improve the face the most. You can inject a bolus into there or 3 injections. But the injections in this area, it need a bit of filler, so this is where we'd heat and use our biofiller tomorrow, and these injections are down on bone. So that's the third thing I'd really like you to do, apart from the microneedle and the papules, is to all do a cheek, or see a cheek, do a cheek, someone with biofiller. Okay, so you're going to draw the Hender's lines, you're going to get that orange needle, and then you're going to go right onto bone, and you'd think it's painful. It's a little bit painful when that orange needle goes through the skin, but you want to actually feel the tip of your needle on bone. So there are only 2 times when we're injecting that we know that where the needle is. One, when we're making a papule, we know we're in the dermis because we're seeing the papule, and another time is when we're down on bone. And when you can actually feel the needle on the tip of bone. It's not sore for the patient, it feels weird, and you need to stay there. So we want to go down, feel the bone, and slowly inject, and gently press against the bone. You don't want to pull up and then be maybe near some blood vessels. So the whole time be down on the bone, inject the volume that you want in the cheeks. It's nice to make 3 little areas, mold it, and then that's your point of beautification. And you'll really see if you do half a side, we're actually doing it in the advanced course this morning, and you get them to sit up halfway. You can't believe how it lifts up the corner of the mouth, improves the nasolabial fold, and even gives support to the eye. So it's a very important injection to use if you're going to go into the volumizing. So those lines are called Hinderus lines, and just to recap, it's from the lateral canthus to the corner of the mouth, angle of the nose to the tragus of the ear, and then you can work anywhere in the upper outer quadrant as long as you are down on bone. Another thing about touching bone with the needle is that it distorts the needle. So always check. So once you've done 1 injection onto the bone, throw your needle away and use another one for the other side. And those are done with that orange 25 gauge needle because it's going to be a thicker substance. Lower face, you can use a cannula, which we'll learn next time, but the lower cheek, because it's part of our V, we're not wanting to volumize the lower cheek at all, but in certain ladies and smokers, they do get very wrinkly. So for me, I just work a lot of the microneedling. And remember that the cheeks are fleshy, so you can go right down quite deep without them feeling pain. And it's all those directions that Dr. Myron showed you. So lower cheek, I don't inject much, I just do a lot of microneedling. Then nasolabial folds. I'm going to show you this slide. So there's a true fold, which is a deep groove that people don't like. But there's also, if you look down here, this person, there's a wrinkle. And that's not a nasolabial fold. So a lot of your early, maybe even late 20s, early 30s, they come in with 2 first signs of aging. So we call it prejuvenation when we're trying to prevent it. So they either come with crow's feet, or they come with a tiny smile line here. So that's not a nasolabial fold, and you don't want to add volume. You want to treat that as a problem area. So if those young ladies come with a little smile line, I don't want to make a bulldog face and add volume. I just want to do my little papules and my microneedling. If it's a true nasolabial fold, the first thing I do is restore the mid-face instead of just filling up this fold. So So I restore the mid-face, and sometimes it improves so much so that you don't need to fill it in. Sometimes you just need to fill in less. It's an area that I really like to use a cannula because it's quite a tricky area. But if it's like this lady who, at the top here, who just has very deep piriform fosses, what we remember from our anatomy is that the artery becomes very superficial at the angle of the nose. So you can do a deep down onto bone injection there as well. And it is quite it's one of the lifting points. So that is another place where you can actually inject onto bone as long as you are down onto bone. Because that facial artery, when it works its way towards the nose, becomes very superficial. So I'd either just do little papules. I wouldn't play around deep with the needle into the nasolabial fold. It's just too risky. But if you're doing the angle of the nose, go down. And if it's just a little wrinkle, lots of microneedling in your papules. Treat it as a problem area. This is a lady of mine. She's 72. And she's been meticulous with her protocols. And what I mean by protocols is when I'm doing the microneedling, I do 3 sessions, 1 month apart. And that's their treatment for the year. So they'll come in month 1, month 2, month 3, and then their skin is unbelievable. And then after a year, if they leave it for a year, they have to start their 3 again. Some people, after those initial 3, they just do 1 maintenance session every 6 months. So, most of my patients just do it, they're so happy, and then after about a year to 18 months, they phone me and they say, no, I need another one, it's wearing off. Same with the hair. But this is one of the ladies who's been meticulous, and she's done her initial 3, which is about 5 years ago, and she comes every 6 months for her maintenance, and she just turned 72, and she's really doing well. But last time she saw me, she wanted her nasolabial folds filled in, and she's a little bit heavy in her lower face. I didn't want to add volume there. So I want to show you, we just did the beautification point on one cheek. And can you see that side that's done? I mean, look at the difference between the nasolabial fold. I didn't even put any volume after that. Okay. And this you'll see tomorrow. When you do one side and you get them to sit up in the mirror, you can't believe what restoring the volume in the upper outer side of the face actually does. So it's, for me, it's always looking at the mid-face first. Well, actually, always the skin as a canvas first, improve that, and then the mid-face. Okay. We're nearly at tea, guys. So, before lips, I just want to tell you a story to wake you all up. In South Africa, our currency is really bad. It's like, I think 17 rands to buy a dollar. So when I come to America, I always go to the Apple store and I trade in my old iPads from the office because I prefer getting dollars to run. So I pass through New York and I go to this very cool Apple store and I've got my 2 iPads from work. And I said to them, you know, how much can I get? So they said, no, we need your Apple ID. So I don't know, it's my work out. So I phoned my staff and I've got them on speaker. And these 2 really cute guys are helping me. And I said, okay, what's my Apple ID for the office, for this office iPad? So my PA says, it's vaginal rejuvenation at gmail.com. Across the whole Apple store. So I think, oh, definitely wasn't worth that $100. So I think, please let the password be something slightly, but luckily the password is numbers or whatever. But basically my point is in my clinic we use PRF for everything. So I won't be doing that again. But anyway, back to the other lips now. So one of the problem areas is these perioral lines. Okay, they usually come in our 40s and 50s, but ladies hate perioral lines. They start putting on their lipstick and their lipstick starts bleeding and it's very aging. So the first thing we do is tell them to stop what's causing it. Stop smoking and stop drinking from a straw. And they're actually really tricky to treat. They do very well with microneedling. So remember from our diagram, that's the one area where you go down and out. I actually get them to put their tongue in there, stretch it out, and I give it a good go with the microneedling and PRF. But I also treat it as a problem area. So I do the papillae first, or you don't actually have to do papillae, you can also just put your needle in superficially and draw it out as a line and inject in. Those of you who have lasers, it's a very nice area. I'd really work with the laser for perioral lines. Okay. Lip volume injections. So what I want you guys to understand, and especially if you've worked with hyaluronic acid or the other fillers before, is biofiller is not one-to-one with the hyaluronic acid filler. It gives lovely volume, it's very natural, but if I have a patient who wants a very structured Instagram lip or very structured Cupid's bow, biofiller is not going to do that. Hyaluronic acid filler is going to do that. So I'll use my Juvederm, Restylane Kiss for that very structured lip. So it's a very nice plumping. Just using the liquid alone gives color back, regenerates the lip, but the liquid doesn't give much volume. Using the biofiller gives a very nice plumping, but it's not very, very structured. But so sometimes in the practice tomorrow, you actually use liquid just to get into the routine of how to inject a lip if it's the first time. If you inject lots of lips, you can go straight ahead and see the consistency of the biofiller. So what I wanted to show you, because there's so many different ways to inject a lip, and you've got Dr. Beth Love tomorrow, who's the most amazing lip injector. So you'll all spend time at her station and use her technique of injecting lips, which looks beautiful. But I wanted to show you, I just wanted to show you what various techniques actually do. And now remember, lips are so controversial between different countries, different states, different age groups. When our last course is in California, and the lip norm there is completely different. Very rolled up, everted. So it's so different per state of what you're willing to do as a doctor, what your patients want. But the biofiller is just going to give you a general plumping. But I want to show you what happens when you inject a lip with different techniques. Okay. First of all, we said that if you take a little centimeter around the mouth, the facial artery now branches into the superior and the inferior labial artery. Okay. The inferior labial artery, not too worried about because it runs sort of beneath where we are injecting. The superior labial is the tricky one because in most studies it runs actually along where we want to inject. So that means we have to really know the depth of that artery. Okay. And that artery in most people, so in only 2% of people, the artery lies above orbicularis oris, superficially. In everybody else, 78% of people, it's actually under, and in the rest, don't make me do maths, is in the orbicularis oris. So we don't want to be injecting into the muscle or under. We don't want to inject deep when we inject the lip. We want to be actually very superficial. And then you've got a far higher chance of being safe because it's actually exactly where we want to inject. So all of these techniques, except a cannula, when you're using a needle in the lip, you actually want to be quite superficial. And you want to know where your needle is, and then you're a lot safer. Okay. So there's a very simple bolus technique. And this technique I actually liked when I was first learning to use filler and trying to see my numbers and get symmetry, where I take a 1 ml syringe of filler or biofiller, and I'd actually divide it up into 0.2, 0.2, 0.3, 0.3. And then the 0.2 I'd do in 2, so 0.1, 0.1, and then on the bottom I would just do 0.3 and 0.3, and that was my 1. And I actually put it in separate syringes so I didn't use more on the one side than the other. I mean, that's a very nice, simple bolus technique that just gives plumping, especially for a normal shaped lip when you're not wanting to change anything. And what happens embryonically when the lip develops is the two tubercles on the top come together closely. So that's what we're trying to emulate, and we get those two tubercles where the light shines, and on the bottom they're slightly wider apart, and that's where the light shines as well. So that's a very basic, easy technique to start when you're doing lips. Another way is to use a cannula, which you'll learn in the next course, but the nice thing is there you have a little bit more relief about the artery, and it's only 2 entry points. So you make your 2 entry points and you do upper and lower lip, and I do a lot of these, I use a cannula for biofiller. But what I want to show you is the other techniques now that are becoming popular and what they do, and there are different names for it. So the extreme version of this is the Russian doll lip, where you see people with their lips up and everted. But remember how we saw how the fulcrum lengthens in aging. So you don't want to add heaviness and drop a lip. And there's a video going around of Victoria Beckham, I don't know when if it's recent, and they've dropped her lip down and out, and she actually can't drink out of her straw. Because we're actually wanting the opposite. We don't want a heaviness, we're actually wanting to evert the lip. The outside of the lip does naturally roll in, so we don't evert it all the way to the edge, but the majority of the lip we want to evert and lift slightly up to shorten that fulcrum again. And how we do that is called fencing. And what fencing is, and remember all our injections are superficial because we're trying to avoid that artery, we're going in just below the vermilion border, going down, and as we're pulling out, we're injecting a tiny thin bit of filler, whichever filler you're using. And that will increase the height and invert the lip slightly. If it's an extreme version and they're doing a lot of fencing, you get that Russian doll type of a lip, which not everybody wants. But it makes a beautiful crisp border. You would actually think that injecting along the border would sharpen the border more, but this makes a crisp border. It increases the height and diverts the lip. However, it gives a little bit of a flat lip. So going in just in the areas where the tubercles are, you can add a little bit of volume, like you saw those boluses earlier. So that's what the fencing, Russian doll lip, but the Russian lip is an extreme version of this, but this is called fencing. Okay. I'll see if
What are
this...
you injecting there? Is it liquid or?
That is actually hyaluronic acid filler. Yeah. But you'll see tomorrow we'll practice all these techniques with the liquid filler, and then if you're very used to injecting lips, you can do it with the biofiller with our lip injectors. So this is, let's see if this works. I forgot that I had a video in here. Bless you. I've got another short video to show you. So what I wanted to show you here is with the biofiller, like I was saying, it's not one-to-one with filler that gives you that very structured lip that you're going to start going with the hyaluronic acid fillers, but it gives you a very nice plumping, it improves color, and it regenerates over time. And just to remind you, with the biofiller, the great advantage is the whole concept behind it. So you've got your nice solid egg white type of a thick to keep the volume, but we've also kept these growth factors cool to keep them alive, because if we heat them up, they're going to die. Mix the two together, so you've got the volume, but you've also got those growth factors in there. So the patients get the volume, but wherever you're injecting it in, they actually get this beautiful glow of the skin over that, and that's because we've left the growth factors in. So that's really what's very beneficial about it. Okay, so I know we're very close to lunch, but I want to do 2 slides on hair. Okay, so if you can bear with me for 2 more slides. Now, for some of you who are dental, hair sounds foreign, but everybody ends up eventually doing hair. And like I said, I'm so